Medical news from MedRxiv. Effect of red blood cell transfusion strategies on ICU-acquired infection in patients with sepsis. A target trial emulation using the Medical Information Mart for Intensive Care 4 database. In critically ill patients with sepsis, the decision to transfuse red blood cells, RBCs, is often guided by hemoglobin thresholds. Yet it remains unclear whether a more liberal transfusion approach influences the risk of acquiring a new infection while in the intensive care unit, ICU. Using a sophisticated target trial emulation of the large, publicly available MIMIC-4 database, researchers found that adopting a liberal transfusion strategy, allowing RBCs when hemoglobin exceeds 7.0 g/dl, did not meaningfully alter the odds of an ICU-acquired infection compared with a restrictive strategy that limits transfusion to hemoglobin less than or equal to 7.0 g/dl. This finding matters because infection is a leading cause of morbidity and mortality in septic ICU patients, and clinicians have long debated whether more aggressive correction of anemia might reduce infection risk by improving tissue oxygenation or, conversely, increase it through immunomodulatory effects of transfused blood. Sepsis accounts for a substantial proportion of ICU admissions worldwide, with infection rates during the ICU stay ranging from 15% to 30% and contributing to prolonged ventilation, organ dysfunction, and higher mortality. Prior randomized trials, such as the TRIC and the more recent TRIS studies, have demonstrated that a restrictive transfusion threshold, typically 7 g/dl, is safe for most critically ill patients, but these trials were not powered to detect differences in secondary outcomes like new infections. Moreover, observational data have hinted at a possible link between transfusion volume and infection, but confounding by indication has limited causal inference. The present investigation therefore sought to emulate a randomized comparison of transfusion thresholds specifically for the outcome of ICU-acquired infection, filling a gap left by earlier work. The investigators identified 4,013 adult ICU stays in MIMIC-4 that met sepsis 3 criteria at admission and applied a target trial framework that created 2 clones for each patient, one assigned to a restrictive strategy and the other to a liberal strategy. Under the restrictive rule, RBC transfusion was permitted only when the most recent hemoglobin measurement was less than or equal to 7.0 g/dl. Under the liberal rule, transfusion could occur whenever hemoglobin was greater than 7.0 g/dl. To mimic per-protocol adherence, the analysis censored each clone at the point of protocol deviation and employed inverse probability weighting within a marginal structural model to adjust for time-varying confounders such as severity scores, organ support, and concurrent therapies. As a complementary approach, a parametric G-formula was fitted to jointly model ICU discharge, death, and infection as competing events, allowing the authors to estimate 28-day cumulative incidences for each strategy. Across the cohort, the adjusted conditional odds ratio for the first ICU-acquired infection occurring at least 72 hours after admission was 0.95, 95% CI 0.80 to 1.14, when comparing the liberal to the restrictive strategy, indicating no statistically significant difference. The G-formula analysis yielded a 28-day absolute risk difference of roughly minus 0.5 percentage points, liberal minus restrictive, with confidence intervals crossing 0, reinforcing the null result. Secondary analyses showed that the 2 strategies produced comparable rates of ICU mortality, length of stay, and total RBC units transfused, suggesting that the lack of infection benefit was not offset by hidden harms or resource use. Subgroup examinations stratified by baseline anemia severity, presence of mechanical ventilation, and use of vasopressors likewise revealed no interaction, indicating that the effect was consistent across clinically relevant patient subsets. From a clinical standpoint, these data support the continued use of a restrictive transfusion threshold in septic ICU patients when the primary goal is infection prevention. The absence of a protective effect from liberal transfusion argues against routine elevation of hemoglobin solely to reduce infection risk, aligning with existing guideline recommendations that endorse a 7G/DL threshold for most critically ill adults. Practitioners can therefore prioritize other infection control measures, such as optimal catheter care, antimicrobial stewardship, and early source control, without fearing that a restrictive transfusion policy will inadvertently increase infection rates. Nevertheless, the study's reliance on retrospective electronic health record data imposes. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.